Hello, everyone, and welcome to today's webinar on digital health and data. Very pleased to have you here. My name is Lena Cordy-Bancroft, and I am Sector Lead for Medical Devices at BSI. Our presentation today, just a couple of housekeeping rules before we get going. You are all in listen-only mode, and this webinar is being recorded. We do want to see your questions, so please put them into the Q&A function at the side of the GoToWebinar panel, and we will get those over to, I will facilitate getting those over to our presenter, Steve, to answer. If you want to do those, just click on the Q&A button at the side panel and post your questions there. Any technical questions, technical difficulties or issues, you can also put into the Q&A box as well. The slides will be sent out to you shortly after the presentation in the next few days, and there will be, but you need to complete the feedback survey first, because we want to hear what you guys think about this webinar and any ideas for future topics. So today's session is really, we're talking about digital health and the increase of data, all that big data that we have with digital, with this technical revolution that we're kind of in the midst of. It's starting. We're there, but we've got a long way to go with everything that with all this new technology that's coming on. And we keep hearing that it's more efficient. It's going to provide more efficient care for patients and allow doctors to have, physicians and clinicians to have more time to assess the patients, and that the availability of data and the digital health apps and technologies will give patients more empowerment to understand their health history, to access the information and communicate with clinicians, and then that it will be an overall improvement for clinicians and healthcare. So we're going to explore some of those questions and see if these are true, or if there's some myths there that we need to break down. And we hope to have this as a conversation type of an experience. So please pop those questions in, and if they are relevant to the moment that we're speaking, we will bring those up. Otherwise, we will address them at the end of the session. So with that, I'm very honored to present today's presenter, Steve Hajjaff. He is Chief Medical Officer of the NODE Group. He is a physician, an epidemiologist, and a health economist by training, and he has been working in digital health space for over 25 years. He's been Chief Medical Officer of many businesses, ranging from kitchen table startups, which is rather interesting. I didn't know there was a startup. They seem like it's like reinventing the wheel, maybe, to multinational companies, mostly in the digital health space. He was also formerly chairman of the British Medical Association, and he currently works as I said previously, Chief Medical Officer of the NODE Group, a contract research organization which specializes to run clinical trials. So with that, I'm going to turn it over to you, Steve, to kind of give us a background and information on digital health and data.
That's super. Thank you, Lena. And a kitchen table startup is one so small that it's around someone's kitchen table, and I've worked at a couple of those over the years. So I guess I wanted to start out with where we are already, if you like, the sorts of things that have been happening to date, particularly around risk and risk prediction. Now we've actually got a reasonably long history. The Framium risk tools are more than 25 years old. They grew out of a heart health study in Framingham, Massachusetts, and they developed these very simple risk models that were very easy, firstly with the data that we already collected in healthcare systems. They were very easy to produce a risk score, and the risk score was in a format that was easy for patients to engage with. So it was, a 10% risk of a heart health event within so many years, that sort of thing. Now there's a following on from that, an organization called Q Research at University of Nottingham's Department of General Practice, also produced a heart health score called Q-Risk. There's now Q-Cancer, and there are alternatives as well. There's the rats that are produced by Exeter, which also looks at cancer. And again, what they've done is they've looked at the sort of complex data set that is in electronic medical records, and looked at associating certain risk factors with certain outcomes, whether it's a cardiac event or whether it's developing cancer, etc., so that they can give a score that's easily communicated to the individual. Now, the combined predictive model and PAR are slightly different. My former team developed these, and these look at the totality, in the case of the combined predictive model, the totality of the electronic health record, both in terms of the hospital record and in terms of general practice and in terms of A&E, accident and emergency departments, emergency rooms, if people are listening from overseas. In effect, by what we did was we developed a sort of taxonomy. We developed categories that represented a particular disease state or a particular risk factor, and then ran what's called multiple regression analysis, which is a statistical tool that showed how well a combination of about 50 or 60, we ended up with, risk factors would combine to tell you the chance of the person being hospitalized in the next 12 months. And this was quite exciting because we ran a trial of this in Massachusetts, not of the combined predictive model, of a different model that we were using in the US. And we showed it was immensely cost effective because we'd identify people who are at risk of getting ill in the next 12 months. We would get health coaches to reach out to them, and they wouldn't end up being hospitalized. So it was very positive. Now, PAR is a similar model. PAR is actually quite similar to the US model that we used for that. Combined predictive model is more advanced. So that was sort of predicting risk for an individual so that health services can intervene. And that's about, combined predictive model was about 15 years ago. So we're coming closer to the present day. Now, Good Thinking was an interesting project, slightly different. It was a project in London, and it looked at what people post on social media and what terms they use in searching, Google mostly. And it produced a score that identified who was at risk of an imminent mental health crisis. And it then took over the advertising in that person's browser to signpost them to individual risk scores, to self-help resources, to statutory and voluntary services to help them with their mental health or their lack of sleep, that sort of thing at that time. So that was again very, very exciting. And this is 3 or 4 years ago, just pre-COVID, maybe a year or so pre-COVID. So that's where we've moved to, if you like, in that regard, in terms of risk prediction and then acting against that risk. And then the final one I'll add is the ALAMA, Association of Local Authority Medical Advisors, which they developed a tool for occupational physicians so that they could assess the risk of someone going to work, or the risk of someone being seriously ill from COVID if they caught it in the workplace. And the way they did that was they looked at all sorts of factors like the person's age, their sex, their ethnicity, and a variety of other conditions they might have. But rather than having a sort of 0.18% or whatever it is score that was difficult to understand, they translated it into what's a COVID age. So someone might have been 55, but because of the conditions that they had, and because because they were male and because they were overweight, for example, their effective age for the purposes of COVID was 85. And that was a really, really easy thing for employers to understand and for the person themselves to understand. So again, it was an interesting evolution of what we were doing, and the back end to that was really just looking at the characteristics. In effect, the electronic medical records of people who were becoming seriously ill. And then triangulating that back. It was a very large multi-center study that was producing the data that then went into that COVID age. So very exciting. But there are still tasks to be solved. Now, this is an interesting example. This relates to liver disease. Now, liver disease is really important because it affects what drugs you can prescribe for a person. This is this is about 5 years ago. We did this piece of work. If someone's got liver disease, then a lot of drugs that we would normally prescribe are either not safe at all or need to be in significantly reduced doses. Now, this looks at the data from general practice, so the family medicine electronic medical records data, the data from inpatients, so for those people who've been hospitalized, and the intersection is where there's data in both places. And what's interesting here is the proportion of people who have liver disease who either when they went into hospital, the hospital didn't know they had liver disease, so they were being placed at significant additional risk through prescribing in hospital, or they've gone into hospital, they've had liver disease identified, and then they've gone back out home, back into the community, and their GP and the primary care team don't know. So again, they're being prescribed for at great risk. And this sort of problem is so easy to solve for with health data, because we can create a very, very simple algorithm. That's exactly what we did in this example, and just ensured there was that it was in effect communicated in both directions, if you like. So there was a shared registry is not the right word, but it's as near as it's good enough. There was a shared registry of people who had liver disease, and therefore particular care needs to be taken with their prescribing. Now, that sort of case finding in that last instance, that was about protecting people's health and their lives, but also there are massive cost implications. Now, this is a bit jargony, my apologies. In the UK, there is an incentive mechanism for general practitioners called the Quality and Outcomes Framework, and it's about identifying people who've got certain long-term conditions and then ensuring that they get appropriate care. And GPs are performance managed on the basis of reaching certain targets. Now, because that is for performance management and it's for funding, the definitions that it uses of the condition or of the health state have to be completely unambiguous. There has to be no question mark around it. So they're quite narrow. The syndromic definitions, which was a piece of work that my former team did, in effect looked at casting the net a bit wider. So let's say, for example, if someone's been coded as having diabetes, but they haven't been coded well, so it doesn't say whether it's type 1 or type 2. Now, that would not be, it doesn't matter the distinction, they're just two different sorts of diabetes. That would not be picked up in the Quality and Outcomes Framework definition, because it's incentivizing good quality coding, but they have diabetes, almost certainly, and therefore they are at the risks that are associated with that condition and will benefit from the treatments that are associated with that condition. Or, for example, they might be receiving certain medications that are only prescribed for people with diabetes. They are not usable for anyone else. Now, there are some drugs that are only licensed for diabetes, but are actually used for other things. So you wouldn't use that to identify a person. But if they're only used for diabetes, then you can use that, or a complication that only happens for people with diabetes. So that's what a syndromic definition is. It pulls in those additional data points from which you can, with a very high degree of likelihood, infer the diagnosis. But what's interesting here is if you look at the cost of care of those people over the next, over that year, the additional people who are picked up by this additional definition, you're talking about between 50 and like 90% a greater cost of healthcare. So just making sure they're on the appropriate care pathway not only is good for their health, as was the case with liver disease, but it also can save the health system a great deal of money. So there's again value in that. And I guess the third piece around this, and again, these have all come from all these last three analyses have all come from a very large scale data linkage exercise where all of the hospital activity, accident and emergency activity, and general practice activity data and clinical data were combined for about a fifth of England, about a fifth of the population, roughly. So fairly large scale. Now this was an interesting one. So what we looked at is people who are on more than 5 or 10 different medicines that they administer themselves. Because one of the things we worry about when people are on a lot of medicines, the data was always about, do they interact and cause problems? But actually, what's just as important is, is there potential for the person taking those medicines to get confused and to, in effect, put themselves at risk? And I want you to look at the sort of fourth column from the left. So these are people who are on 5 different preparations. Now, that's not a lot of medicines. There's lots of us, I imagine, here at this webinar who are taking, 4 or 5 medicines, but that have any degree of cognitive impairment for whatever reason, whether it's from an injury or whether it's from early dementia, whatever. And let's look at their costs, both for total cost of care and emergency care relative to the third column from the left, all patients. And you can see, it's 4 or 5 times higher for all care and 10 times higher for emergency care. And the thing here is there's a really simple intervention where we actually just give people one of those boxes which says what tablet to take at which time of day. And we can potentially forestall a lot of that cost to the system and also the cost to the individual. Now, we wouldn't have been able to do that without either someone thinking it was a good idea and doing some hypothesis-based research, which was unlikely because there's loads, there are a million competing hypotheses, or with this large-scale data linkage exercise and being able to identify where some of these pain points were in the system. Incidentally, these people also had 20 times the normal rate or the age sex matched rate of broken hips. And broken hips, A, cost a lot of money, B, they cost a significant number of lives, and C, can cause great pain and discomfort for an individual. And we've always been told that they're not preventable. Well, other than, through stair rails and things like that, actually they are, just simply by helping people manage their medicines better. I don't want to, I won't spend too long on this. Again, this is just looking at where there's variation in good healthcare. And the sort of the columns, if you like, are the proportion whose blood pressure have been kept below a certain level, and the diamonds on the slide are actually the average risk score of those people. So of the people with diabetes in those particular institutions, general practices. So there is, as you'll see, there's just no correlation. So it's not patient factors that are driving suboptimal care. It's doctor and practice factors. And that, again, that's really important. It's really important to be able to do these analyses and to sort of cross-reference against the risk scores. In this case, it was the combined predictive model that I talked about earlier. To be able to actually then have a conversation and say, well, there's something that's being done differently here. What can we do to make things better? And this is another one that's just I'm not going to dwell on this one. This just relates to people being referred to hospital for heart disease. And again, there's no relationship with the number of people with heart disease or heart failure, which is the maroon graph along the bottom. The blue columns are the referrals, and there's no real relationship with the risk scores amongst people who have heart disease. So again, this one, and my apologies for the sawtooth effect, that's for administrative reasons. But this one really does debunk the well, my people are iller, that's why I send more people in. And if we were to deal with that unwarranted variation, I mean, we're talking about an immense cost saving to the health system, a reduction in anxiety for those patients who are being referred inappropriately, some of them, and also an opportunity benefit where health services aren't being used for those who are less ill. There's more opportunity to treat those who are more ill. And again, without doing these data analyses, it really would be impossible to have those conversations. This one is just about, I think quite often people will make the mistake of looking at a single indicator and think that that means something. Actually, it can be very, very important to triangulate multiple indicators. So these are data from a company called Methods Analytics, and they're looking at outpatient referrals. And if you look at the top two, you'll see that in this particular geographical area, it's way, way above the average. The black line is the mean. The white is one standard deviation to the mean, the light blue 2. So you're talking about a way, way above average level of outpatient referrals. And then if you look at the proportion of outpatient referrals in that geographical area where they're only seen once, again, a massive outlier. So you start thinking, well, maybe they're sending people in who don't need to be seen as much as in other parts of the country. Because if someone needs to be seen, then often they'll be seen more than once, often multiple times. And this is also borne out by the third chart below, again showing that the ratio between first appointments and follow-up appointments is very low. Again, from 4 standard deviations below the mean. So in the bottom point, 1% rather of the country. So again, there are issues around whether people were ill enough to need to see a specialist. And again, the last one is the proportion of people who need to actually go on and have a procedure after the appointment. And again, very, very low. So this one's straightforward because it all points in the same direction. It all says this is people who are weller than need to be being sent to be seen at hospital. Interestingly, if you look at the graph below, you'll see that there's a massive variation by the general practice. So clearly it's institutional factors that are driving this far more than patient factors. The next one's a little bit more, it's the same sort of thing, but it's slightly different, because for each of these, there are multiple explanations. So the top row is the average length of stay for people with what are called ambulatory care sensitive conditions. So things that can be treated and you can carry on your way. You don't need to be in overnight. So that's very short. So it could be that the treatment of those conditions is really good. And likewise, the average length of stay for emergency admissions, which is the second row, again is very low. So it could be that that people are getting better very quickly and so going home quickly, but it could be some other things as well. It could, for example, both of these could be people are being sent into hospital when they're well, and they could be cared for elsewhere. And the third is the same for over 65s admitted in an emergency. So all three of those could either be really good, efficient care, or they could be a predilection to send people into hospital too early. The fourth one, the blue row, is the Charleston Comorbidity score. And that's the number of different diseases on average that people who go into the hospital have recorded. And it's very low here. So again, there could be two reasons. The population could be healthier than those who go into hospital elsewhere, or the hospital could be really, really bad at coding. So what we end up with between these four is that we've either got multiple different explanations or we've got one explanation, with that explanation being that healthy people are being sent into hospital. And with all four, and actually the two below sort of bear it out as well in a different way. But by having those different data points, you can really debunk the likelihood of it being multiple different factors, and actually say this must be what's going on. So nearly through these. This is an interesting piece, because we get very concerned, and we build services and we build models that are around treating disease in the hope that that will bring benefit to the patient and also bring benefit to the system. Now this is diabetes, and what's interesting about this is that only about 4% of the cost of care for people living with diabetes is for their diabetes, their hospital cost of care, that is. And about, I don't remember what it was, I think it was about 11% or 17%, okay, were all of the potential complications of diabetes. Now that's not the attributable portion, that's every conceivable complication. So some of them would have had cataracts, for example, if they didn't have diabetes, but we're counting that as a complication of diabetes anyway. So between that, that's what, 21%. So the remainder is 79%. The rest of the cost of the care for people with diabetes, 79%, is nothing to do with their diabetes at all. But they get twice as much of it as people who don't have diabetes, for all sorts of factors around that relate to how they interact with the system, how easy it is to get passed from one team to another team, and all of those reasons sort of conspire together. So we do very, very worthy work around managing a particular disease, but what we're not doing as well is supporting the whole person to make the decisions that are overwhelmingly in their own best interests. And it's only with looking at reflecting data like these, and again, this is from the same big data linkage as the first three slides, only through looking at data like these that we can reflect that back to policymakers and to treating physicians. And I think Lena was going to come in at this point.
Yeah, thanks, Steve. We do have a question, and actually we have a attendee question. Who is actually responsible for analyzing and validating the healthcare data? Who, is there a specific area in the hospital, or is it outsourced? Who does this stuff?
And that's a really interesting question, because the answer is, well, nobody really, or everybody. And that's a big part of the problem. That's a part of the issue we had to solve for. So that work I was doing, those 4 slides with the big data linkage, was with a private company called Health Dialogue that was offering services to health economies on a risk share basis. So we'll save you this much, and we'll keep that much of what we save. The capacity within the health service itself to do these analyses is limited. Methods Analytics was another company that was the sort of scarf-like diagrams, who offer services either to hospitals or to payer organizations like clinical commissioning groups. And there are some national bodies that do some of these analyses and reflect it out. But there really isn't a consistent approach even across England, let alone across the UK. And it's very much about capacity and capability in the individual organization, and willingness to ask themselves the difficult questions.
Well, I think do you see that there's a special skill set that's required in order to be able to analyze this kind of data? Do they have to have some kind of a medical background in order to make the correlations, or do they have to have more of a statistical background? Are we going to see a change in the skill sets of clinicians going forward?
So I think that's a very sensible question. For some of it, there needs to be an understanding of the system. So not necessarily a medical background, but a sort of immersed in healthcare background. For some of it, there needs to be a statistical background, but we need not to. I think one of the examples I'll come to later of projects that haven't worked is about where there was too much trust in the statistics. And actually, there needs to be the ability to triangulate to the real world as well, because statistical association, doesn't necessarily mean causation. There's the old story, isn't there, about the population post World War II, the birth rate and the correlation with the stork population of Western Europe. And there's a wonderful correlation, but it's not causation. But storks don't bring babies, despite the hallmark greeting cards. And it's
so much easier.
It would be. So there needs to be the sort of specialist area knowledge, expertise, in order to interpret statistical associations. And that's just as true in just about every area of life, actually. It's not just a healthcare problem.
And some of those slides that you showed, one of the notes I made is a question, sometimes it looks like we're trying too hard to find correlations that aren't there. And I think that, when we have so much data and we're able to look for stuff, we want to show we have a hypothesis and we want to prove it, and it's not there. Like, we start looking at data and trying to make a story that isn't there. And we have to be careful of doing that.
There was sorry.
No, go ahead.
So there was an old adage many years ago about politicians, but it applies to clinicians just as well. It's using data the way a drunk person uses a lamppost, for support rather than for illumination. And I think it's very real. Confirmation bias is a very real thing, even unconsciously, and that's even where there isn't the conscious desire to obfuscate.
Excellent. All right, we do have another question coming in, but I'm going to move on to, we'll bring that up in a little bit. I want to get into this myth breaking. I love Mythbusters. Fortunately, we don't have any fun videos or experiments that we can try here, so we're just going to kind of talk to these. Um, this myth here that digital health is for the younger, more tech savvy generation. We know that the percentage of the global population that has access now to the internet in the last 16 years or so has dramatically increased, and there are and that allows for opportunities for advancing care for seniors with the use of telehome care, the telecare. We've seen that with through COVID and stuff, as well as we're able to help patients of all ages understand the complex health and medical information during consultation. I think it's really interesting the access to the internet with the world population versus the developed, but we see an increase here with the developing nations as well, coming real close to where we are with the rest of the world. So I think that's that's something we need to think about. But this myth here about being it's for the younger, more savvy generation. Do we think that, or do you see does digitalization improve the well-being of certain societal groups, leading to maybe more health inequalities because of maybe this misnomer in the concept of technology?
So I think there is a risk of exacerbating health inequalities, but perhaps not for the reason of internet savviness or whatever the expression is. Now, we talked about predictive risk models and that sort of thing earlier, but of course you can only predict risk when you have people's data, and people from certain population groups don't engage with healthcare in the same way. If you don't engage with healthcare, the healthcare doesn't have your data. So that's people from certain minority ethnic groups, people with mental ill health or substance misuse issues, men. All of these are groups that don't necessarily engage with healthcare appropriately. So some of that sort of outreach to manage risk can't happen. So that will drive inequalities in that way. I think there's also an issue with the global south, if you like, because even if there's internet access, what there isn't necessarily is electronic medical records and the ability, when delivering healthcare, to identify risk. So you can calculate someone's body mass index, which is a measure of how overweight a person is. Not a great measure, but it's something. You can do that with the calculator on your phone. That's straightforward. That could probably be done anywhere in the world. But a predictive risk model like the combined predictive model, or even Q Cancer, isn't really doable unless you've got electronic medical record data and all that sort of thing. So that will drive inequalities between nations to a degree. But the part of the idea of using risk prediction is so that it's not just the squeaky wheel that gets the oil. It's not just the sort of health savvy, more affluent people who seek help when they are concerned about something, but also those people who are less well informed and have less access to care, but we have enough data to predict that they might be at increased risk. So I guess it's a two-edged sword. There is always the risk of increasing inequalities, but we're probably, if we're doing that, we're doing it in the context of sort of raising it up for everyone, if that makes sense.
Yeah.
So it's not as bad as if we're only raising it up for those with less need, if that makes sense.
We have a kind of related question here from Linda, who's attending as well. What about the digital divide, as some groups cannot access or afford current technologies, and technology obsolescence results in technology being out of date due to major corporations, changing their updating their software and stuff like that. So related to this myth, I think.
Yeah, I mean, I think that's certainly going to be an issue for as we start going down the road of individualized risk scoring for the person themselves rather than for health systems, because health systems find it a bit easier to update than some individuals do to update their technology, etc. I think that will drive the digital divide. You know, if you've got a shared phone between 5 people, then it's not going to be tracking your motion accurately. So that sort of the predictive thing around your physical activity or your heart health or whatever it is that capacity is lost. So I think there is potentially an issue there. What I will say is that a lot of the sorts of analyses that we're talking about are actually computationally light to deliver the scoring. Developing the algorithm, might need lots of very expensive hardware. But once you've got it, once you've got it there, it's actually fairly computationally light. Now you still need a computer or a mobile phone or something. You're not going to be able to do it yourself on a pocket calculator. But actually, some relative devices from 10 years ago could probably calculate all of these risk scores that we've talked about even now.
Thank God we have computers, because that's more than what my brain can compute, I think, sometimes. All right, myth number 2, digital healthcare allows clinicians more time with patients. So we know that clinicians have a certain amount of time in a day, a week, a month. But with the digital healthcare, we're told, oh, we'll have increased efficiencies, and that will allow, have, lead to reduced waiting times for patients, and then allow more people to be helped. On the other side, we know that there's a shortage of doctors. It's becoming very important. It's in various parts of the world, in critical need. We also have increased use of online consultations, which means that more patients need to be helped. So what we're not realizing the sufficiency that we thought we would have for clinicians to spend more time with patients is no longer really the case. So, do we feel, in this kind of a situation, and with digital health generating a large proportion of I don't know how large, a larger proportion of probably false positive results, because you're not really sure, as we're growing this data and as we're learning the algorithms, because we're not there yet. It's an ongoing scenario. Are we leading to more concerned patients making unnecessary doctor's visits and really upsetting the balance here of who needs to be seen? I think you addressed this earlier with people going to the doctor without a need for it, and so that's causing this influx of digital healthcare is not allowing clinicians more time with patients. How do you see that?
So, yeah, I think you're right, but I would attribute it to other broader societal trends. I think that we self-care less than we did a generation or 2 generations ago. We live more isolated lives than we did a generation or 2 generations ago. So some of that sort of, I don't know what the word, the wisdom, if you like, around health is harder to communicate within family units and within community units. So I think that's a driver of need for services to step in to help at that point. So that's a driver of demand. I think that information online can be helpful or extraordinarily unhelpful. And we don't, I think few of us have the skills to sift what's beneficial from what's nonsense. to be frank. And why would we? You know, it's one of the reasons why we have doctors or engineers or lawyers, because actually we need agency. We need people who have scholarship in a particular field to work through sort of complex interplay of risks and benefits. It's very difficult for us to take it on ourselves. And I guess the third piece is, I think to an extent we've been oversold because it drives share prices. We've been oversold the benefit of I mean, I'll talk about remote monitoring in telehealth later, but things like that, or AI in diagnosis, we've been oversold those benefits, and so there is that expectation, and they have to err on the side of caution. So you do get lots of false positives that drive demand. And then finally, systems haven't adapted yet. So I'll give you an example. My GP uses telephone consultations to triage face-to-face consultations. I have a bad knee at the moment, nothing serious. I have a bad knee at the moment. I talk to I make an appointment, I wait, you know, a week. I talk to my GP on the phone, who triages it, says, yes, you've got a bad knee, so it needs to be examined. So you need to come into the surgery. And so there's another appointment another week later, which is fine. I mean, you know, I understand that, but it means that my care has taken 20 minutes rather than 5 minutes. And it's just, it's, what's the word? It's maturing systems such as those sort of perverse incentives don't sit there. You know, it's reasonable to do telephone triage. It makes sense for people who you know, can be reassured fairly easily, or who need a prescription, nothing else, that sort of thing. But in some cases,
I had a recent, just this week, where I did an online evaluation assessment to see, you know, oh, what could I do? Did I need to go in? Probably 20 minutes to go through all these questions. And I was like, okay, did I do this right? Then they said, oh, we'll get back to you within, you know, probably 24 to 48 hours. All right, that's a bit of a wait. But it came back even quicker than that, saying, sorry, yeah, we don't do this over the computer yet. You're going to have to give us a call to come in. Like, oh, okay, so complete waste of time. And, you know, if there was, you know, that's my time, and there's cost to that as well, right? So I think, you know, this isn't, I don't think we're going to see digital healthcare as the cure-all, you know, this magic thing to solve our healthcare issues, but it's got some ways to go, but it can at least help prove some efficiencies, I think. All right, I know we're getting close to the time, so let's go to myth number 3. Patient-doctor relationships are improved with digital health. So with the digital health, we know that we have more patient engagement, patient empowerment. They're able to hopefully understand more about what's going on, and maybe partake in the discussions with their care plan. But then with that, patients expect more attention. They want their questions answered. They're going to come in with more background, more details. They've got the internet at their hands, and if WebMD says it's so, then it must be. So, you know, prove me wrong. There's a lot more data and computer time for clinicians to sift through all this data. And then the productivity demands, just knowing that, yep, just because, you know, the time is more efficient, they've got more patients coming in now, they need to get through this, and it's going to lead to more patient, you know, clinician burnout. The stress, you know, we're going to see difference in how the doctors are handling the patients, and this overall relationship. The bedside manner is really coming more of a computer side manner. So do you think that digital health can improve healthcare efficiency, increase patient engagement, and enhance the role of prevention? Or are we biting off too much too soon with this?
I think technically it can, but I think practically it can't yet, because we're not adapting our systems and our thinking appropriately. You know, I talk to my sort of friends and colleagues who are consulting remotely, and how can I put this? The decision has been made by someone somewhere to sweat the assets massively. So they might well be going for 3 or 4 minutes, very short consultations with patients, one after the other, after the other, after the other, without any break. And that's not efficient. It looks efficient, but it actually isn't, because what you do is you just fight the fire that's immediately brought that person there, but you don't solve the underlying problem, so they come back a week later. And I think that sort of move a lot of widgets quickly mentality has been re-empowered by the move towards remote consultation. But I think once the systems settle and grow and mature, if you like, then I think that we can deal with queries through expert systems that will feed information to patients. We can provide sort of communities of care where patients can engage and can feel empowered and share stories, and we can not overstress the assets in terms of the human resource delivering healthcare.
Great. All right. Myth number 4: digital health leads to lower quality of care for patients. People like that connection time with the doctor. That, hey, this is about me. Give me my attention. We know that digital health is not. It's not intended to replace in-person visits. We know this at the core. But understanding it and knowing that it's happening. Really, are we seeing this? And serious medical conditions will still require in-person visits. So there is going to be that human contact. We also know that virtual visits are convenient. You just take a call, it takes less time as long as they're calling you and you don't have to sit on hold for 20 minutes, 30 minutes to get through. But they are really good for requests such as prescription refills or referrals for a specialist. And so from a patient perspective, it's some of these these phone consults, virtual visits can be more convenient, have faster access to the care, the less missed work time. You don't need to worry about the commute time. So you have 5 minutes with the doctor versus the hour to travel there, sit and wait, and an hour to the time to travel back. And it allows for this continuity of care. You've got this ongoing connection with your doctor. And so what we're seeing is, in the past we've had this model of care where we have the doctor working with the people, and it's a very personalized one-to-one, and we've got a relationship there. And with the digital, then you have doctors working more with data, and it's looking at the data and assessing that, maybe using some of that time that could be spent with patients, and then so becoming more of a digitalized level of care. So with this digitization requiring doctors to analyze huge amounts of data in the electronic health records, it's going to take some years before the AI systems really can take over that task and learn this. We're not there yet. So until then, doctors will have to spend more time looking at the relevant data and knowing what's there, and yeah, maybe outsource it if needed. But we don't have time for that when the patient is waiting outside and they're going to be coming into the room. So this creates a very different care model, I think, from what patients and healthcare providers are used to. What impact might digital health have on the future of the medical profession? Are we going to be looking at a future where doctors assess data more than really looking at that patient? Or are we going to see a different skill set in these doctors, where in the clinicians, where they need to understand the statistics and be able to read the data rather than really focusing on the physical patient there?
I think that's the multi-billion-dollar question. I think there are areas where it's straightforward. Teleradiology works and it's cost-effective, and I don't think there's any question marks about that anymore. I don't think there's. I think telepathology likewise. So some of that stuff, some of the laboratory-based and imaging stuff, quite clearly works in that way. The problem is, so my first doctorate was on expert systems in diagnosis. And it was really, really interesting. If you looked, and this is like, 25 or something years ago. If you look at the expert systems that we were producing then, they had about the diagnostic accuracy of a good medical student, but nowhere near as good as an experienced clinician. Now, if you look at what's being produced now with machine learning, setting aside really rare disease that nobody ever sees ever, and you're looking at ordinary disease, the accuracy hasn't improved. And the reason for this, in my view, is that there's an enormous amount of unconscious data that the treating physician processes. So you might, unconsciously notice a smell or feel a different texture when you shake, or see a different type of movement when someone walks into a room, and all of those things play into the system. So, and those will not be captured in my lifetime through digital health. And so I think that there's a baby in bathwater risk here, and we need to be aware that we may actually be losing accuracy as we go down the digital route. We get a spurious reliability because it's numerical, but we lose validity because there's loads and loads of data that are missing. That said, even in a digital healthcare world, we can still have personalization. I think there's immense value in a patient having a medical home, whoever that is, an individual that is their first point of contact. And I think there's overwhelming evidence from all sorts of studies that show how important that is.
Excellent. I think that kind of leads into this last myth as we close out the session today, and that is that digital technology has revolutionized patient care. I think what we've heard is that it hasn't yet. Will it? Right now, we know we've got traditional care; it's the status quo, and we're layering digital health on top of that, which has this misnomer that it's a solution for all problems. And if we continue this route, just taking what we have always done and putting the digital health and the data on top of it, we're just going to get what I call the status quo plus. It's what we've always done. We're still inefficient. It's more expensive. We've got more data. So I don't think that's the solution. What we need is take that traditional care, that status quo, where we have the patient clinician relationship, add in the digital health, the solution for all problems, but then we also need to add in a shift, this paradigm shift in our healthcare model. How do we change that so that we can adapt to this data and move forward? And with that, I think that's how we're going to get into this new digital era of healthcare, where we will see more efficiencies. It's patient-oriented, it's precise and individualized, everything that we want. But we won't get there if we continue to stay just the way we've always done it and add the digital health on top of it. So very quickly, I know we're at the time. How do we, can we transform this current care model into one that is more compatible with digital health in order to improve healthcare by providing seamless connections? Is this it, or are we just looking at a utopia?
It's really difficult because there's sort of the move fast and break things mindset can be really, really useful and really valid in driving paradigm shift. But the problem is in healthcare, there are a lot of things that can get broken. And actually some of them might well be very important. And sometimes the idea that everyone agrees is a great idea isn't. So my team led the biggest ever evaluation of telehealth, remote monitoring. And everyone in the world was saying, remote monitoring is the future. It's going to solve problems. And we ran a large scale trial in the UK, but it's still the biggest that's ever been run. And we showed not only was it not cost effective, it actually made patient outcomes worse. And yet the whole world was saying this is the solution. And I think we need to make sure that we've proven things are the solution before we tell the world that they're the solution. Let's move slow and don't break things, I'm afraid. And when the evidence says this can shift the paradigm, then let's shift it.
Excellent points there, and I agree. Yes, we want change, we need to do it, but we don't want to break something. And in the meantime, we need to be able to mold and adjust with it and make it an evolution rather than just a break and change type of a scenario. So, wow, lots of excellent information, and it just gets you to start to think that yes, we have a long ways to go here, but we've got some brilliant minds and some really passionate people about this that will lead us down that path, and we'll get there eventually. Maybe not in our lifetimes, but in our grandchildren's lifetimes for sure. So thank you very much, Steve, for joining us today. It was a very interesting session. We did have some great questions from our attendees, and I thank you very much for that. The information for the survey will be sent out to you to give us feedback on the session, and then the slides will be provided as well. And thank you again, and we look forward to seeing you at more BSI events in the future. Thank you, Steve.
Cheerio, thank you.